Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In the second part of our discussion with Professor Edward Bullmore, we turn towards treatments for depression as well as its prevention. How effective are antidepressants? How could inflammation be targeted to reduce depressive symptoms? Could the public sector play a role? And there are a lot of anti-inflammatory drugs currently approved and currently used for a number of different conditions. Yeah. Could these potentially be used to control depression?
I think there is potential to do that, yeah. I mean, we looked at this in clinical trial data. So over the last 10 or 20 years particularly, there's been a huge number of studies looking at anti-inflammatory drugs for various different medical disorders. We collected data from, I think it was 18 trials, which had used various different anti-inflammatory drugs for disorders like rheumatoid, psoriasis, inflammatory bowel disease. But in each of these trials, although the primary endpoint, the primary focus was physical disease, they had also measured as a secondary endpoint, they'd measured a questionnaire which gave us some information about mood and capacity for pleasure. And if we analysed those trial data in terms of the impact of treatment on those questionnaire measures of depressive symptoms, we saw a significant anti-inflammatory effect. And, we did that meta-analysis, and that is, I think, the third published meta-analysis of randomised clinical trial data to come to the same conclusion. And there was a paper published in October, which generated quite a lot of general media interest, where a fourth meta-analysis was published looking at studies of non-steroidal anti-inflammatory drugs, including aspirin, for example, and again showed that in those studies, which were individually small-scale studies of these drugs for treatment of depression, there was overall there was a robust effect of treatment. So in a way it's a remarkably consistent story, that anti-inflammatory drugs tend to have mood boosting effects. Again, you might have seen this for yourself, or you may well see it in future as a junior doctor, because there's anecdotal evidence as well to support this. There's a thing called the Remicade high. I don't know if you've ever heard of that, but the clinical anecdote is that patients with arthritis given their first dose of an anti-TNF antibody, so that's an anti-cytokine antibody, a protein that will block pro-inflammatory cytokines in the circulation, often report feeling a lot better within 48 hours. In fact, I remember when I was first getting interested in this area and trying to persuade people in the pharmaceutical industry to invest in anti-inflammatory drug treatment for depression. I talked to my boss at the time, and he said, I can buy this as an idea, because I can remember when, this is my boss speaking, I can remember when I was a physician that the nurses on the ward used to compete with each other to be the nurse that would set up the anti-TNF treatment drip on the patients with rheumatoid, because the patients would immediately feel better and they'd love the nurse for giving them that treatment. So there is this sort of anecdotal story about anti-inflammatory drugs having quite rapid onset, mood-lifting effects in patients with arthritis particularly, and there's all this meta-analytic evidence in clinical trials.
So I guess from my perspective, two questions come out of this, and the first is, have we got any data to show perhaps a correlation between cytokine levels and between inflammation and depressive symptoms? If we know that there's perhaps a sliding scale of depression severity depending on inflammation severity, can we actually track this relationship a bit more quantitatively?
Yes, and we've done that, and you can show that cross-sectionally it is the more severely depressed people that tend to be more inflamed. It's also often people that have persistent depressive symptoms despite already having been offered treatment with standard antidepressant drugs, so-called treatment-resistant depression. So more severe depression, more treatment-resistant depression tends to be associated with greater levels of inflammatory markers. What I think would be very nice to have, but I don't think it is in the literature at the moment, would be more longitudinal data. So because depression waxes and wanes, if you follow people over time and their depression becomes more or less severe, can you see an echo of that, or maybe a precedent of that in terms of increases and decreases in inflammatory proteins? That would be very nice data to have, but I don't think anybody's done the longitudinal study to get it yet.
It'd be interesting to see what sort of relationship comes out when we look at groups of people without this comorbid depression, just with major depressive disorders, treated with anti-inflammatory drugs.
Yes, you're absolutely right, and we've just started a trial here in Cambridge to do that. So we are looking at the effects of an anti-inflammatory drug offered in conjunction with conventional antidepressants to see whether that makes a difference for patients who have severe depression that has not already responded to conventional treatment.
And speaking of conventional antidepressant treatments, what sort of efficacy are we currently seeing from these treatments in the general population?
Sort of SSRIs and conventional drugs. Yeah, so all of these drugs, as you know, they all target the transmitter systems in the brain: serotonin, noradrenaline, dopamine, the so-called monoaminergic transmitter systems, and they get a pretty sort of bad press in some ways. And I'm not saying they're without their problems or complications, but again, if you step back and you look at the data, and you look at the clinical data, the clinical trial data we have on existing antidepressant drugs, I think it's again clear beyond reasonable doubt that they're better than nothing. They're better than placebo in randomized trials. Significant superiority. But the effect sizes are not big. So, as you know, you can talk about effect sizes on a standardized scale. So something like sort of effect size of 0.2 or 0.3 would be sort of small, 0.3 upwards, more medium size effect. And antidepressant, the gross mean average effect size of conventional antidepressants is about 0.2, 0.3. Small to medium effect size on average.
So that's a gross mean that's not taking into account an estimated a third of people who don't respond very well at all.
Yes, that's right. I think that's probably the main argument against complacency is, if you look at the clinical trial data, on average there is significant treatment benefit, but as you just said, an average can conceal a lot of variability, and there are a lot of people that really don't see any benefit from antidepressant drugs. So I think part of the problem with antidepressant drugs that we have already, they've been massively oversold, and this goes back a long, long way. They have been sold as if they could help everybody, as if they are a sort of panacea, they're magic bullet, and that is clearly not true. And I think part of the controversy around antidepressant drug treatment probably stems from the way that they were introduced into practice and sold. I think if you were to take a more nuanced view, you'd say Prozac and other conventional antidepressant drugs are pretty safe, they're pretty cheap. There's no particular reason not to try an antidepressant drug if you're depressed, but it may not work. It's not going to work for everybody. And at the moment, we don't have a very good way of predicting who's going to respond or who's not going to respond. But I think if you think about it like that, instead of thinking, do these drugs make everybody less depressed? No, they don't. That's clearly not true, but nor is the sort of converse true, that they're no good for anybody. The reality is a bit more boring and a bit more sort of grey. They work very well for some people, but not for others.
And Prozac has been around and approved for quite a long time.
Yeah.
And I know you mentioned in your book the idea of psychiatry rather standing still in terms of depression treatment. But actually we've had a few recent excitements with, for example, Ketamine with sleep deprivation therapy as well.
Yeah.
Do these fit in with our model linking inflammation and depression, or are they acting perhaps in a different way?
Well, I think the ketamine story is particularly exciting because that is, that's a pharmaceutical that has got FDA approval, it's got regulatory approval as a new treatment for depression, and it's a completely different mechanism of action. It's not, unlike Prozac, unlike all the other antidepressant drugs, it's nothing to do with serotonin, noradrenaline, dopamine. It's not monoaminergic. It works on glutamate receptors. It blocks glutamatergic transmission. And actually, that could be related to inflammation, because there's quite a bit of evidence that when you make the brain more inflamed, one consequence of that is to increase glutamatergic neurotransmission. So it may be that ketamine is working on brains that have been pushed in a more glutamatergic direction by an upstream effect of inflammation, maybe.
And yeah, interestingly enough, ketamine works far faster than traditional antidepressants, which is, I guess, it sets it aside and makes it even more useful, perhaps, in this context.
Well, I mean, I think the company that developed it, which is Janssen, I should say Janssen's involved in our research, so I'm not like a completely detached commentator on this, but I do think Janssen deserve a lot of credit, because they recognised that it worked rapidly, and they've done trials looking specifically at its efficacy in situations where you want a rapidly acting antidepressant. So, for example, if you go to the casualty department, the A&E department, and you're asked to see somebody that's been brought in because they've just taken an overdose and they're still desperate to commit suicide, driven to commit suicide because of depression, you don't want to wait 6 weeks for Prozac to kick in at that point. To have something that is rapidly acting could be very advantageous. And Janssen dared to do those trials and show that their drug worked rapidly in that particular clinical population, which is a very brave thing for a pharmaceutical company to do. So I think they deserve a lot of credit for pushing it in a very, it's an innovative approach, not just in terms of the mechanism of action, but also the sort of clinical setting. It's designed specifically to treat acute, desperate, potentially life-threatening depression, not necessarily as a long-term treatment for milder symptoms.
And perhaps bridge that gap between, as you said, more traditional therapies and the actual episode itself. Which is strange, because it almost sits in marked contrast to the actions of other companies, perhaps maybe a decade ago, pharmaceutical companies such as GlaxoSmithKline, which are also affiliated with, and AstraZeneca, which have been moving away from psychiatry. Why has there been perhaps this loss of interest?
Well, so I should say I used to work for GlaxoSmithKline. I worked for GSK half-time for 12 or 13 years, but I don't work for GSK any longer. And so I was working for GSK as it happened at the time that they decided to pull out of psychiatry. And, that was 2010. As you say, Astra and other companies, other big companies, a lot of them made the same move at about the same time. And the reason why, in a business sense, is very, very simple. They were putting in a lot of money to research and development for depression and various other psychiatric disorders. I mean, in the order of hundreds of millions of dollars every year. And out of that had come nothing. No new antidepressant drugs had made it onto the market. By the time GSK closed psychiatry, the company had been investing on that scale for a decade, and nothing had emerged into the market. Now, if you're a businessman, you just look at that and you think, well, it's a bad bet. I mean, we're putting all this money in, nothing's coming out. It's not a very difficult decision from a business point of view to close down. I think from a sort of clinical and a scientific point of view, it's perhaps a more interesting question, why, despite all that investment, had there been so little return on investment? Why has psychiatry drug development proved so difficult? And you ask different people and you'll get different answers. But personally, I think a big part of the special risk of antidepressant drug development in the past has been the assumption that there is a drug out there that's going to work for everybody. That we don't need to stratify, we don't need to predict response, we don't need to do anything like that. We just need to find lots of people with depression and give them the chance to take our new wonder drug. And if we do that often enough, we try enough wonder drugs, maybe eventually we'll find the one that really is wonderful. Whereas I think a much, much better strategy, and the strategy that has been adopted in most other areas of medicine, is to say, okay, you've got depressive symptoms, but why? What's the cause? Is there a cause of those depressive symptoms that we can identify in a blood test or a biomarker or some other, so-called companion diagnostic, and then target our treatment program, our R&D drug development program should be targeted precisely on those people who are most likely to respond. Now, I think that is a very different way forward for drug development in psychiatry, and it's an approach that is tractable if you're thinking about immune targets, because we can read off the state of the peripheral immune system very easily through a blood test. So, I like to think that it's imaginable that we'll move into a new era of psychiatric drug development where increasingly people will be using biomarkers to identify the subgroup of patients most likely to respond, and then targeting the development program in that way.
And given that we already have quite a few anti-inflammatory drugs for different purposes already FDA approved on the market, is there perhaps more interest in repurposing drugs that are already approved and avoiding expensive clinical trials, or developing new drugs?
Well, there's a lot of talk about repurposing, and on the face of it, repurposing is an attractive option, certainly from the economical point of view, because what repurposing means is, let's say you take a drug that's already marketed. That means it's already got through regulatory approval, it's already known to be pretty safe, otherwise it wouldn't have been licensed. There'll be a lot of background data on that drug, and you can think of all of that as sort of sunk investment. There's that basically any marketed drug represents a huge prior investment.
I think the latest estimate I saw was $2.6 billion for every prescription drug brought to market in terms of cost, including failed drugs and things like that. So it's an enormous cost.
It is a huge cost. So every marketed drug represents a big investment, and if you repurpose a drug, essentially you're leveraging that prior investment, so you have to make less additional investment to push the drug forward in the new direction, in this case the treatment of depression. So as opposed to the alternative approach might be, for example, let's say to start with the genetics we were talking about earlier. You could say, okay, we know the genetics of depression, let's start there, and let's try and invent a drug that sort of hits the genetic target for depression, and let's take a drug all the way through the development process from that point of view. But that's going to take years and years and years, and it's going to require millions of pounds of investment before you get to the same sort of probability of success as you would have by repurposing something that was already marketed, was already well known pharmacologically, already had a good safety profile, and so on. So there are a lot of kind of, I would say, business arguments in favour of repurposing. It basically saves money on the earlier stages of development. But there are also some caveats. So, for example, one important caveat is that a lot of the drugs that have been marketed for physical disease have been designed not to get into the brain. So, and the reason for that is that if a drug gets into the brain, it has the potential to cause side effects. So it's been quite sort of sensible for many companies when they're developing their drug for rheumatoid arthritis, they'll design it so it doesn't get into the brain, doesn't cause side effects, but that means that drug is not a very good candidate for repurposing for depression, because it's been designed not to get into the brain and do anything there. So that's just an example of the way in which one, I think, has to be quite thoughtful about repurposing. It's not like you can take any old anti-inflammatory drug and chuck it into a trial for depression and it's going to hit the bullseye. You need to think carefully about, how that drug works, where does it get to, and what does it do when it gets there.
But even so, will some pharmaceutical companies perhaps be slightly worried that actually new drugs for treating depression could be actually just repurpose generic drugs with no margins from them.
See, yeah. Well, you're touching on a very interesting point there, which is, I mean, there is some evidence, I mentioned it already, that aspirin works for depression.
I can get a packet of aspirin for 30p in the shops.
Yeah. But there's no business in that. I mean, nobody's ever going to make any money out of developing aspirin for depression. So I think if you look at it from a commercial point of view, you'd have to say we'll just have to be cleverer than aspirin. We'll have to identify, what is the precise mechanism in the brain that is most likely to cause depressive symptoms, and maybe that is susceptible to treatment by a new drug that we can develop. Or maybe you can pair the development of a drug with the development of a diagnostic test to predict the response to that drug, and that would give you a sort of perhaps a commercially viable, marketable package. Or you could commercially focus your development on, a particular niche or type of depression. A lot of people you mentioned pregnancy as a sort of immune event. A lot of people are interested in perinatal depression, postpartum depression. Is that possibly a more sort of tractable target for the development of new drugs? So I think, if you accept that repurposing of generics doesn't stack up as a sort of business proposition, and you're a businessman or woman, you'll need to think about some cleverer pharmacology, or partnering the pharmacology with a companion diagnostic, or thinking about going into an area where there are special risks but also potentially special benefits for patients. If you're not a businessman, you could think, well, isn't there a way that we could, maybe the public sector could invest in the trials that were needed to support repurposing of generics? And I think that is an idea that is maybe worth reflecting on quite seriously, because actually this is bigger than psychiatry. There's a lot of drugs out there now which are marketed and which might be very effective for other indications than the one they were originally licensed for, and there could be a major public benefit, a major public good in finding a way of incentivizing repurposing of those drugs that are already marketed or generic. I don't know what the answer to that is, but and I don't want to get into a sort of party political issue, but I think it's quite interesting to reflect on some of the ideas that have been coming out about greater public sector investment in the pharmaceutical industry. I mean, I think we've thought of that always as sort of capitalism, private sector, profit motivated, but to my mind, there's no reason why there couldn't be a different investment model. Maybe it makes sense for a country like the UK with a big national health service. If the state invested, I don't know, £100 million in the development work that was needed to show that aspirin, for example, could be safely used to treat depression in some patients, maybe there's a health economic argument to show that £100 million of investment, which supports the repurposing of a generic, pays back to the NHS in, I'm making the numbers up, £1 billion worth of saved disability due to otherwise treatment-resistant depression. So, I think this is an area where, some interesting things could happen over the next 5-10 years or so around the business model for drug development. And does it always have to be in the private sector and profit motivated, or could it sometimes be in the public sector and motivated more by the health economic benefits of the public good?
I guess it could be a case of actually making sure the expertise is there in the public sector to actually go through these trials, which obviously pharmaceutical companies are very accustomed to carrying out. But
that's right.
Maybe a teaching hospital might not be as...
No, you're absolutely right. There's an awful lot of expertise in the pharmaceutical industry which is not well matched or well represented in either the NHS or in the academic sector at the moment. But I think that's a fixable problem. I think if the public sector worked out a sort of business model, if you will, for repurposing of generics, I think you could attract the skills or train up the skills that you needed to actually deliver that strategy in the public sector.
And it's occurring to me that there is already a large population taking these drugs, for example, aspirin or ibuprofen already. So could we perhaps tag these investigations onto trials for new drugs looking at targeting an inflammatory condition, but also perhaps actually recruit from just the general population of people already taking these drugs?
Yeah. So to the first point, could we put more, questionnaires, let's say, for measurement of depression, fatigue, or other psychological symptoms? Could we put more of that, those kind of endpoints, could we put them into clinical trials for medical disorders? I would say absolutely yes. And I don't really understand why that isn't already happening. I think it would make a big difference. And to my mind, it's a pretty easy thing to do. Next time a big company is running a phase 3 trial of rheumatoid arthritis, just get the patient to fill in a questionnaire, and they could do it on their phone. They don't actually have to come into a assessment unit or anything like that. Just every a week after treatment, 2 weeks after treatment, collect mental health data. Because if you could show that the anti-inflammatory effect on depression in a medical disorder like inflammatory bowel disease, for example, if you could show that the antidepressant effect preceded the drug effect on the physical disorder, that I think would help ultimately in making a licensing claim that you discovered a drug that worked for both the physical and mental symptoms of the inflammatory disorder. It wasn't just that people were feeling better because their inflammatory bowel disease had cleared up. So basically, I completely agree we should be companies should be putting more focus on measuring mental health outcomes in clinical trials of anti-inflammatory drugs for non-psychiatric disorders. Absolutely.
And perhaps moving slightly away from drugs and towards excitement for other non-pharmacological interventions, is there room for different techniques for reducing inflammation?
Yeah, I think that's a good point. And obviously, I've come into this area from the perspective of drug discovery. But I think it's very important for people listening to this who may not be particularly interested in drug discovery, or maybe interested in non-drug treatments for depression. I think it's very important to understand that I think the link between inflammation and depression is bigger than drugs. It's bigger than drug development, and it could open the doors to non-pharmacological treatment. For example, we were talking earlier about the factors that can cause inflammation, that causes depression, obesity, stress, for example. So lifestyle changes that target the source of inflammation, whether that's sort of weight reduction or some kind of stress management program, could be motivated by, or indeed monitored by, demonstrating that they have anti-inflammatory effects in the first instance, which are of antidepressant benefit in the future. The microbiome gets a lot of press these days, and as you know, the lining of the gut is absolutely packed full of immune cells, and the lining and the gut itself is full of these bacteria, the microbiome, some of which are hostile. So I find it quite easy to imagine that a change in diet changes microbiome, maybe elicits an immune response. So I think there's a lot of opportunity, and a lot of people are interested in diet and inflammation, and potentially using dietary manipulations to change inflammatory states and maybe to improve mood states as a result. And if you'd asked me 5 or 6 years ago, I'd have said, well, that's nonsense. Because again, when I was at medical school, diet, we were taught, is vitamins, calories, proteins. That's basically all you need. The idea that there were sort of subtler variations of diet that could have effects on something like mood, I mean, that would have seemed completely, nuts, actually. But again, I think the science is moving in a way which should encourage people to think a little bit more open-mindedly about this. If you change diet, you change microbiome, could that change immune response? Could that have effects on mind, brain and body that we need to understand in medicine a little bit more deeply than we do at the moment? So that's one non-pharmacological approach that I think is going to would benefit from a lot more research. I mean, I must have to say, if you just go onto Amazon and you type anti-inflammatory diet, for example, there are a lot of books out there already that claim to be able to give you the recipe for menu choices that will reduce your levels of inflammation. And as I say, I'm open-minded to the concept, but I would like to see much, much better quality data on the immunological effects of dietary change. I don't see, I've looked through a few of these books, and in a lot of them I don't see the evidence. I see recipes, and I see some, wishful thinking about, what turmeric might do to your immune system, for example. And I think we ought to investigate that. But I think it needs the same level of rigour and the same standards of proof, roughly speaking, as for a pharmaceutical intervention. A dietary intervention, in my opinion, could be very useful. It could offer people a way forward, which many people might find more acceptable than taking a drug. But I think it needs the same level of proof, the same level of evidence.
And is the pharmaceutical industry interested in this, or do they perhaps shy away from non-pharmacological interventions, or are they perhaps broadening their view on what actually treatment could entail?
Yes. Well, so, of course, the pharmaceutical industry is big, and there are a lot of different companies trying different things. And, there is a word, nutraceuticals. I don't know if you've ever come across that one before. Nutraceuticals. It's kind of like, it's the idea that you can have a sort of nutritional ingredient, so a dietary change with a kind of pharmaceutical-like effect. So companies are working on that. There are companies working on the microbiome and how you might be able to manipulate that. It's not mainstream industry thinking, no. But I think there are, within the industry, there are companies beginning to think about that sort of thing. I think that there are other stakeholders in this who are not part of the pharmaceutical industry that might be wanting to think, what more could we do? If you're a psychotherapist, for example, or you are a yoga practitioner, or you do some kind of anger management training, a lot of these practitioners will be working with people that are depressed. Could they sort of inform their practice or develop new techniques or be more confident in predicting who's going to respond or not respond by building evidence that any of those interventions might also have anti-inflammatory effects? Sounds a bit crazy, but there is some evidence in the literature already, for example, that meditation or yoga can change the immune state of the body. So, I would encourage people to think, whatever their ideas about how depression should be treated, whether it's drugs or diet or lifestyle or psychotherapy or vagal stimulation is another modality that is relevant in this respect. However you think depression should be tackled, I think the ideas of the immune system interacting with the brain to cause behavioural changes is potentially relevant, and I think people should look at it regardless.
And do you think that perhaps this greater mechanistic understanding of depression could be quite liberating for people around the country, around the world with depression, who might until now perhaps think it's their fault in some way, or a result of their actions? Actually, it could perhaps remove some of the stigma around it.
I do very differently. So the stigma thing is still significant. I think it's shifted a bit in the last 5 or 6 years, particularly. I think I think your generation and younger, maybe the impression I get is that you are more confident in speaking out about mental health than my generation was, and I think that's very progressive and a good thing. But there is still clearly a lot of stigma. What do we mean by stigma? We mean shame, a sense of that you are personally responsible, or it is a personal failure to have become mentally ill. We're talking about secrecy, people not wanting to talk about it. And, if you go around the world and you look in other cultures, it can be very extreme, the stigma associated with mental illness generally. And my view is that actually we've always stigmatized illnesses or diseases that we don't understand. You know, if you go back historically, you look at tuberculosis, cancer, epilepsy. Leprosy is the classic example. Whenever human society has been confronted with illnesses, disorders that, you know, the provenance of which we don't understand, we have a tendency to shun the afflicted, you know, to push them apart, to stigmatize them. That's what we've done. And the lesson of history is that the best remedy for stigma is deeper understanding. Because as soon as you understand where leprosy comes from, you understand it's a bacterial infection, you understand when it is or when it isn't contagious, and you understand how you can treat it, the stigma just vanishes. I'll give you, and I think that's going to have, you know, I hope that will have a big impact in the future of psychiatry, because I think psychiatry still, mental health generally, is still suffering or still living in the shadow of stigma. And I think deeper understanding of particularly physical causes, biological causes, I think is particularly liberating. I'll give you an example. One of the other areas where the immune system is impacting on mental health is in relation to psychosis. So that is to say madness, to put it in common parlance. You know, people experiencing hallucinations, delusions, and so on. And some colleagues of mine here in Cambridge many years ago, you know, they saw a young man come into the NHS with a first episode of psychosis. And, you know, as is typically the case, this patient was surrounded by a very concerned family, but there was also a tremendous amount of shame about it. You know, what had happened? Was it their fault? Was it their fault? Was it his fault? Whose fault was it? Anyway, my clinical colleagues did an interesting thing. They thought they'd do a blood test and see if this patient had antibodies against the glutamate receptor, actually the same glutamate receptor that's targeted by ketamine. And they found that he did have high levels of this autoantibody, and they gave him a treatment that cleared the autoantibody, and he got better. But also the stigma just popped, disappeared. You know, as soon as they could say to the family, you know, your son is psychotic because he's got these antibodies in circulation, and when we've taken the antibodies away, he's better. The stigma, they told me, I wasn't directly involved, but the story was the stigma just dissolved. So it's not the madness itself, it's not the hallucinations and delusions that create the shame and the secrecy, it's the ignorance about where those symptoms come from and the lurking suspicion that it's, as you said, somehow one's own fault or one's family's fault, one's parents' fault. And there's been a lot of that in the history of psychiatry, and I think it's extremely unhelpful. And I think as we get deeper biological understanding, that is going to be one of the big benefits. I foresee much less stigma.
And even though perhaps, as you acknowledge, this might not necessarily fill in the whole puzzle, it's certainly filling in a chunk of it, and hopefully cases like that will be far more common in the future as we do gain more understanding of this and trial data comes back.
Yes, I hope so.
Professor Bullmore, thank you so much for joining me today.
Okay, it's been a great pleasure.
It's been a fantastic conversation.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts if you have a moment, and you can also reach us via our website and our social media pages.